Hello and welcome to MK's Exam Secrets. This is Season 1, Pediatrics Season Finale. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at 6 exam questions in one clinical course. Because this is a season finale, we shall look at 10 exam questions in one clinical course, it being Pediatrics. If you haven't yet subscribed to the channel, subscribe to the channel, hit the bell notification icon to be receiving videos and notifications every time I post. Grab your piece of paper, grab your pen, and let's go. Hit the like button as well and comment in the section below if these videos are really helping you. So, question 1. Kaluya, a 3-year-old toddler, is admitted with severe acute malnutrition. He is commenced on feed and antibiotics in a warm environment. The following day, he has a tonic-clonic fit, his blood sugar is normal, and he has no signs of meningeal irritation. Part A, what is your most likely diagnosis? Part B, what feed may he have been given? Part C, give one important physical feature you would look for besides the fit. Part D, write down 2 investigations you would carry out and their likely findings. So you may pause the video right now and comment in the section below what you think the answer may be. I will give you 4 seconds. Okay, so here comes the answer. So most likely this child has a syndrome that we call refeeding syndrome, which is usually a complication that occurs in these malnourished children that are started on high carbohydrate or high calorie feeds. So what will happen is that once you feed these children with these high calorie feeds, you cause a rapid fall in certain electrolytes such as phosphate, such as magnesium, such as potassium. And in addition to this, there's also going to be expanding of the extracellular space volume. So there may be some edema. So this child may present to you with features of CNS disease. So they may have the seizures, they may have alterations in the mental consciousness, and they may also have some cardiovascular symptoms. They may have some arrhythmias that may be there. They may even have generalized body weakness. So most likely this child was started on Formula 100 or F100. Remember that the 100 means that in 100 meals you get 100 kilocalories. So instead of you starting them on F100, ideally they were supposed to be started on F75. Give one important physical feature you would look for besides the fit. So you'd look for tremors, you would have hyperactive deep tendon reflexes, you would have hyperactivity to sensory stimuli, you would have muscle fibrillations or fasculations, you have a positive Shelf-Stick sign and a Trozier sign, which is more or less to do with calcium. Because remember that the metabolism of magnesium is almost similar to the metabolism of calcium. Even the functions of these two ions go hand in hand. So remember, in one of these signs, that's the Shelf-Stick sign, you pretty much tap on the anterior aspect of the tragus in front of the ear. Remember, that's where the facial nerve is coming out from. So if you tap that area, you get these spasms of the facial muscles, and that is indicative of a positive Shelf-Stick sign. Then a Trozier sign, you simply wrap the arm around you wrap a BP cuff around the arm, and then you keep inflating the cuff. So once the systolic pressure of the cuff exceeds the systolic pressure and the diastolic pressure in the arm, then there are going to be these spasms of the carpal muscles. So you may also have carpal spasms, you may also have vertical nystagmus, and write down 2 investigations you would carry out and their likely findings. So you order for serum electrolytes, you may get low levels of magnesium, low levels of phosphate. If you so wish, you can actually collect a 24-hour urine excretion and test it for magnesium. You also want to do an ECG. You may find many things on the ECG. There may be ST segment depression, there may be toe-picked T waves, there may be flattening of the T waves or depression in the precordial limb leads, or the precordial leads rather. You may also have U waves that are present. You may have loss of voltage in the ECG. There may be prolongation of the PR interval as well as widening of the Curious complex. So question 2, Mumba, a 7-month-old infant and HIV infected. He is wasted and recently diagnosed with pulmonary tuberculosis. He has oral thrush and generalized itchy papular skin rash. Tease out all the clinical features and assign each a stage according to the WHO scoring system. Write down his overall WHO stage. Mumba displays delayed developmental milestones. Write down 2 possible causes. What treatment regimen would you put him on? So I'll give you 4 seconds to think about this and write your answer in the comment section below. Remember, 25% of the people watching these videos are not yet subscribed, so please hit the subscribe button. Share these videos to someone who is writing exams and wish them the best. So here comes the answer. So this child has wasting to begin with, though they haven't yet told us whether this wasting is moderate wasting that is responding inadequately to treatment or severe wasting that is not responding to treatment. But if this child is indeed wasted, we shall assume that there is this severe wasting that is not responsive to treatment. And if you get a wasting in a 7-month-old children, it means it must be significant. So we'll put that at stage 4. The pulmonary tuberculosis is at stage 3. Oral thrush is at stage 3. Generalized itchy papular skin rash, that's the PPEs, or pruritic papular eruptions, you put that at stage 2. So you go for the highest staging of the clinical features. So this child is going to be at stage 4. Mumba displays delayed developmental milestones. So write down 2 possible causes. It may be due to malnutrition that may be evident because of the recurrent bacterial infections that we see in HIV patients, or even HIV-associated enteropathy. Remember that HIV causes flattening of the villi and the microvilli in the gut, so this affects the absorption of nutrients, the absorption of food from the gut, and it may lead to a malabsorptive syndrome in HIV patients. You may also get HIV-associated CNS disease or some CNS opportunistic infections that may lead to delays in the developmental milestones. What treatment regimen would you put him on? So abacavir, lamivudine, and lopinavir. So ABC, 3TC, and lopinavir. Boosted lopinavir, right? Lopinavir and ritonavir. Question 3. A 7-year-old girl is admitted with a history of recent enuresis, which is pretty much bedwetting, unexplained weight loss, and vaginal candidiasis. No history of tuberculosis or tuberculous contact. Her rapid test for HIV is negative. What is your differential diagnosis? What is your most likely diagnosis? Write down 2 more symptoms that may be associated with your most likely diagnosis. List down 3 investigations to ascertain your diagnosis. So I'll give you 4 seconds to think about this. So here comes the answer. So this child could either have diabetes mellitus, diabetes insipidus, and urinary tract infection. I think diabetes insipidus may be new to some of you watching these videos. Remember that diabetes insipidus is a problem to do with ADH and how it works. Remember that ADH is produced in the hypothalamus and released from the posterior pituitary gland. It functions to go and cause reabsorption from the kidneys via the insertion of an aquaporin 2 channel. So in diabetes insipidus, there are 2 variants of the condition. You have what is known as a central diabetes insipidus, where you're not producing enough ADH from the areas where it's being produced and secreted. The second is known as peripheral diabetes insipidus, where the ADH receptor isn't responding to the ADH that's being produced. So whichever case it may be, you're not reabsorbing the water, so most of this water is lost in the urine. So you have this diuresis, which can be at night, which is referred to as enuresis. So what is the most likely diagnosis? So type 1 diabetes mellitus, because this girl has lost weight and she is young. So those are the features of type 1 diabetes. The other 2 symptoms she may have is polydipsia and polyphagia. List down 3 investigations to ascertain your diagnosis. So you could do a random blood sugar or fasting blood sugar. You could also do an oral glucose tolerance test. You may do a urinalysis. You may check for serum electrolytes, creatinine, urea, and serum levels of ADH. Question 4. A 13-month-old boy is brought to the OPD because he is not gaining weight. He is exclusively breastfed, and mother tells that he sweats profusely while taking feeds. He was treated for bronchopneumonia at 2 months of age. On examination, his weight is 7.3, his heart rate is 156 beats per minute, and his respiratory rate is 30 breaths per minute. What is your most likely diagnosis? Write down additional physical findings expected on examination. List down 4 investigations to confirm your diagnosis, and write down 2 possible complications related to this condition. So I will give you a 5-second interval to think through this question and give me your answers. Okay, so here comes the answer. So most likely this child has a cyanotic congenital heart disease. And this is how they present to you with. You get typically a child, if it's missed at birth and it's not really as so significant, you'll get a child has this history of sweating profusely, especially when they're breastfeeding. Sometimes they may even turn blue when they're breastfeeding. And remember, a child has to choose between two things. They have to choose whether they will continue feeding and run out of oxygen, or they'll have to choose to have oxygen and not feed. And I think that the choice is pretty much clear, even to you. If I was to give you an option to eat and run out of oxygen, or to have oxygen and not eat temporarily at that moment, most of us would go for the second option, unless if you're part of that majority that would rather die than starve. So most likely this child has a congenital cyanotic heart disease. And another test that you can actually do is check the oxygen saturation on this child. If the rule of thumb is this, if you give oxygen and the oxygen saturations improve, it means that most likely this child has a respiratory cause. If you give oxygen and the saturations do not improve, then it's most likely that there's a cardiovascular cause, because both of these can affect the oxygen saturation. They may present to you with cyanosis. So most likely this child has a cyanotic congenital heart disease. Write down additional physical finding expected on examination. So there may be peripheral or central cyanosis. There may be a loud, harsh systolic ejection murmur. There may also be finger clubbing. Write down 4 investigations to confirm your diagnosis. So you do a chest x-ray, an echo, an ECG, and full blood count with a differential to rule out any infections, to rule out any anemia, to rule out any thrombocytopenia or thrombocytosis. Then the ECG is, of course, to rule out any abnormalities of the heart, electrical conductivity. Echo is, of course, to see the actual defect in the heart. The chest x-ray may show you features of a boot-shaped heart in the case of a tetralogy of Fallot, horizontalization of the ribs, even oligemic lung fields. Write down 2 possible complications related to this condition. So it may be a thromboembolic accident, there may be heart failure, there may be pulmonary regurgitation, there may also be arrhythmias. Moving on to the next question. Question 5. So this is a karyotype of a baby born to a 30-year-old mother. Write down the abnormality in this karyotype. So you can look at the karyotype. What is the gender of this child? What is the diagnosis? Write down 2 crucial investigations you would carry out within 48 hours of the baby being born. Write down 4 congenital abnormalities related to your diagnosis. So here's the karyotype. I will give you 6 seconds to look at it closely and then think of what possibly this could be. Remember, don't forget to write in the comment section below. Okay, so here comes the answer. So most likely, this child has an extra chromosome at chromosome 21. As you can see here, there are 3 chromosomes as opposed to 2 chromosomes everywhere else. So this child has an extra chromosome at chromosome 21. Then what is the gender of the child? This child is female, because remember there's no Y chromosome, but there are 2 X chromosomes. A female is XX, a male is XY. So what is the diagnosis? This is trisomy 21 or Down's syndrome. Write down 2 crucial investigations you would carry out within 48 hours of the baby being born. So you want to do your thyroid function test, your T3, T4, and TSH. You also want to do an echo and ECG of the heart, because this child may be born with this congenital heart defects. So write down 4 congenital abnormalities related to your diagnosis. So there may be cardiovascular conditions such as congenital heart disease. There may be some GIT associated congenital conditions such as Hirschsprung's disease, which may cause congenital megacolon. There may be imperforate anus. There may be an annular pancreas. You may have duodenal atresia. You may even have umbilical hernias. Question 6. Mwetwa is born to a mother living with HIV. He weighs 3.1 kg at birth and is exclusively breastfed. The mother started taking antiretroviral drugs 8 months into her pregnancy. Question A. Write down the prophylactic ARV regimen you would use on Mwetwa. Question B. What question on history would you ask to assess risk of infection? Question C. Mention 3 advices you would give the mother to ensure she does not pass the infection to the baby. Part D. How long would you advise the mother to breastfeed the baby? Part E. In a succinct manner, write down the timeline of the HIV testing and type of test at every milestone as part of follow-up of Mwetwa. Part F, if it turns out that Mwetwa's NAT results is positive, what ARV regimen would you start Mwetwa on? So we'll give you 4 seconds to actually think through this question. And here comes the answer. So you would put Muetua on AZT, zidovudine, lamivudine, and nevirapine. Then what questions would you ask on the history? So you would ask for the mother's pre-pregnancy and pregnancy viral load. You would ask for her CD4 count. So if the viral load is very high and the CD4 count is very low, there is a very high risk of HIV being passed to this child. You would ask what drugs the mother is on, what regimen is she on, is she taking the drugs, is there any compliancy to the drugs. You would ask for the mode of delivery, whether this child was delivered via cesarean section or this child was delivered via spontaneous vaginal delivery. And then if there were any complications that were associated with the delivery, any trauma that was associated, what was done to the child when they were born. Then if they hadn't yet given us information about breastfeeding, you would also ask if this mother was exclusively breastfeeding this child. So mention 3 advices you would give this mother. So number 1, exclusive breastfeeding. The chances of HIV transmission are much, much lower in children that are exclusively breastfed versus children that are mixed fed. Then number 2, the mother should also continue taking the ARVs as they are prescribed. Number 3, she should administer the prophylactic regimen as well as cotrimoxazole prophylaxis to the child as long as the child is exposed. And then she would ask you, how long should I breastfeed my child? So as long as she wants and as long as she's taking the ARVs rigorously and she's monitoring her CD4 count and viral load. But WHO actually advocates for 6 months of exclusively breastfeeding. After this, they recommend to wean the child off. Why? Because the child may be developing teeth. They can easily bite the breast. And then once they bite the breast and the nipples begin to crack, there may be some bleeding that may be there and easier transmission of HIV. So what test are we going to do? So you do a nucleic acid test at contact. You do it at 6 weeks, at 3 months, at 6 months, at 9 months. Then once you reach a year, you start off by first doing your serological test, your rapid test. And if it's positive, you confirm with your NAT. So you do this at 12 months, you do this at 18 months, you do this at 24 months, and also at 6 weeks after cessation of breastfeeding. And if indeed any of these tests are found positive, you put the child on AZT3TC and boosted lopinavir, which is lopinavir and ritonavir. Question 7. You walk into a mall with your 4-year-old toddler and she picks a pack of food with the following nutritional information per 100 grams. Proteins 10 grams, maize 40 grams, wheat flour 50 grams, millet flour 25 grams, olive oil 4 grams, palm oil 6 grams, zinc 11 milligrams, potassium 110 milligrams, vitamin A 800 micrograms, and folate 230 micrograms. Work out the energy content of this pack. Considering that your child's daily caloric requirement is about 160 kilocalories, how many packs would she require to cover this need? So I will give you 10 seconds to think through this and give me your answer. Okay, so here comes the answer. So what you need to remember is 1 gram of proteins or carbohydrates gives you 4 kilocalories. Then 1 gram of fat is going to be giving you 9 kilocalories. So you calculate the total amount of proteins that are present in this pack. So there's only 10 grams. Then you calculate the total number of carbs that are present. So there's 40 grams plus 50 grams plus 25 grams. That will give you a total of 115 grams. Then you find how much fats are present here. So there is olive oil 4 grams, palm oil 6 grams. So that gives you 10 grams. Then zinc doesn't give you any energy, so there are no calories from that. Potassium, no calories from that. Vitamin A, there are no calories from that. Folate, there are no calories from that. So you say that because there are 4 kilocalories in 1 gram of protein or 1 gram of carbs, so you say 4 multiplied by the total grams of proteins, that gives you 40 kilocalories. Then you multiply the total carbs in grams times 4 to give you the calories that the carbohydrates are giving you. Then you multiply 9 by the total grams of the fats. So that will give you 40 and 460 and 90. Then you summate all this to find the total kilocalories that are present. And that gives you around 590 kilocalories. And if you want to change this to kilojoules, you simply multiply the answer by 4.2. So that means they will have 2,478, my bad. So in the next question, if the calorie is 16 100 or 1600 kilocalories. Remember that one pack is giving you 590 kilocalories. So how many packs do you need in order to receive 1600 kilocalories? So you divide the 1600 kilocalories by 590. So that gives you 2.711. But you can't get 2.711 packs. And remember, nutrition is never rounded down. Whether you were to get 2.1, 2.3, 2.4, 2.5, you would round everything up. So this child would need 3 packs to cover this calorie deficit. So question 8. A 3.5-year-old female child presents with noisy breathing and fever of 6 hours duration. Prior to this, she had been perfectly well. She was born at Levi-Mwanawasa General Hospital at full term with a birth weight of 3.9 kilograms. There was no neonatal problems. Her routine vaccinations are up to date and weight gain has been adequate. There is no family history of note. On examination, the patient looked very ill with temperature 39.7, pulse 110 beats per minute, blood pressure 110 over 78 millimeters of mercury, dribbling of saliva from one corner of the mouth, intercostal and subcostal indrawings with a clear chest. Blood investigations reveal HB of 12, WBC of 20, with 84% of them being polymorphs, 12% of them being lymphocytes, sodium 135 millimoles per liter, potassium 3.5, urea 4.6, and the urinalysis was normal. Question A, what is the most likely diagnosis? Question B, what is the most likely causative organism? Part C, name 3 management measures you're going to institute in this child. So I'll give you 3 seconds to think through this. So here comes the answer. So most likely this child has acute epiglottitis. Why do I think this? Number 1, there is a high white blood cell count. Number 2, this child has features of respiratory distress. And of course, number 3, this child is drooling from the corner of the mouth. So remember the D's of epiglottitis, the drooling and the dyspnea and sometimes the dysphagia that may be there. So the most likely cause of the condition is Haemophilus influenza type B, which is why we started vaccinating children against it. The 3 measures that I'm going to take: airway and breathing management. So I'm going to perform controlled nasal tracheal intubation. So I'll consult the anesthesiologist. I'll consult ENT specialists. Then give this child humidified oxygen by a hood or a face mask. Keep this child in a sitting position and avoid examining the throat because you may exacerbate the condition. The second management measure I'm going to institute is starting them on steroids. So I'll give them dexamethasone 0.3 to about 0.5 milligrams per kg. I'll repeat this 8 hourly for a maximum of 2 or 3 days. Then the third measure is I'm going to start them on antibiotics, preferably broad spectrum antibiotics such as a 3rd generation cephalosporin. So I'll start them on cefotaxime 100 to 150 milligrams per kg per day. I'll give this intramuscular and in 2 injections for 5 days. So question 9, you are called to review a newly diagnosed insulin-dependent diabetes mellitus case. The patient is receiving insulin intravenous and his morning urine analysis is as follows. Specific gravity 1.025, proteins plus, the pH is 6, the blood is negative, ketones 4+, glucose negative. Explain in few words what may have led to the presence of ketones and the absence of glucose in urine. In your opinion, what would be the blood sugar levels in this patient? Low, normal, or high? And then part C, how would you manage this patient? So I'll give you 30 seconds to actually think through this question because I'm very interested in what you think the answer may be. And again, if you still haven't yet subscribed, then you're delaying yourself from getting daily content from these videos. And if you want me to keep making such videos, please drop a thumbs up in the comment and smash the like button. And let's get it as high as possible. Share the link as well so that we can reach out to the rest of Zambia and eventually go and conquer the world. But for now, let's keep focus on this question, and I hope you have your answer ready because I'm about to give you the answer right about now. So this possibly could be that this child received a very high dose of insulin the night before. So remember that if you give insulin, this is going to be driving virtually almost all the glucose in the bloodstream into the cells. So it means that there's going to be hypoglycemia that's going to be there, and there's going to be hunger that's going to be there. Now, because there's hypoglycemia and there's hunger that is present, it means that this is going to lead the body to respond to this hunger by producing ketones, okay, or ketogenesis. Remember that ketones are used as an alternative source of energy. So the three main types of ketones, you have acetone, beta hydroxybutyric acid, and acetoacetate. So these are going to be in high concentration in the blood. They can be filtered out in the urine, and eventually you find them positive in the urine. The reason why you do not have the glucose is because there's hypoglycemia. You give this person a high dose of insulin. That's what I think is most logical in this question. So obviously the blood sugar may be low. How would you manage this patient? So check your random blood sugar. If the blood sugar is low, give them 5 mils per kg of 10% dextrose. Then adjust the insulin dose and monitor the glucose 30 minutes to about an hour. Give intravenous fluid infusion of dextrose in normal saline. Then also monitor the ketones and glucose in the urine. So the last and indeed the final question of this season finale. Hamaundu, I almost read this as Hamdudu. Hamaundu, a 4-year-old boy, is brought to the OPD with edema of both hands and feet and sores in the mouth. He weighs 8.5 kg. Assign the nutritional status to Hamaundu based on Wellcome classification. How many milliliters of F75 would you need to cover his caloric requirement, estimated at 1,500 kilocalories in 24 hours? So I will give you 20 seconds to think through this question. Okay, so here's the answer. If you are thinking very slow, I am so sorry, but you could have paused the video in order for you to get the answer first and have that satisfaction of getting it right. So here's the answer. So first of all, we have to estimate how much Hamaundu is supposed to be weighing. So remember, for a 4-year-old, the formula is 2 multiplied by 4 plus the age. So 4 plus 4 is 8. 8 times 2 is 16. So this child is supposed to be weighing 16 kilograms as a rough estimate. But this child is weighing 8.5. So they're actually weighing 53.1% of the expected weight. And remember, this child has edema of both hands and the feet. And according to the Wellcome classification, this child has marasmic kwashiorkor. Then how many milliliters of F75 do you need to cover this caloric requirement, estimated at 1,500? Remember that 100 mils of F75 gives you 75 kilocalories. So if 100 mils of this F75 is giving you 75 kilocalories, then how much volume will you need for you to have 1,500 kilocalories? So you say 1,500 kilocalories multiplied by 100 mils divided by 75. So you would need 2,000 mils. So therefore, this person needs 2,000 mils per day of F75 to cover this caloric need. I hope you really understood this math. If the problem is with the math and not the science, then I think you should work on that before you write your exam. And with that said in mind, I would like to wish you all the best in your pediatrics exams. And if you have any questions, feel free to connect in the comment section below. Do not forget to subscribe, hit the bell notification icon to be receiving notifications every time I post such videos. And drop a like, drop a comment, share the link to someone